grateful, Dr. Vedam, for your presence here to give us this presentation on SBRT for pancreas and liver cancers. And with that, I'd just like to pass time over to you.
All right. Thank you, Michael, Benjamin, and everyone else. It's a real pleasure to be here with you. Before we go forward, I just want to make sure that everyone's able to hear me well. Okay, perfect.
I think we can.
All right. So I do want to mention that although I'm presenting the talk today, all the slides from this talk are actually courtesy Dr. Gabriel Sawakouchi, a very good colleague of mine, who is actually the one who's working on the GI service. I myself specialize in GU/GYN, and Gabriel has been very generous with sharing these slides that he prepared with me for this talk. So thank you, Gabriel. So this talk is essentially going to be focused on pancreatic cancer and liver, essentially cancers in the GI tract, and how we apply SBRT techniques to these types of cancers. And as you can see, when they present with these types of tumors, about 10 to 15% of them are resectable through surgery, and about 40 to 50% develop some sort of metastasis, and so chemo is the more preferred option. And this is more specifically for pancreatic cancer. Now, there's also another section, which is the locally advanced unresectable segment of the population, which is about 30 to 40% of the cases, and they are unresectable because of various reasons. And so what are the options for these types of patients, or patients who present with these unique features? And so radiation therapy does have a role to play amongst this population. So currently, pancreatic cancer can only be cured if the primary tumor is removed surgically. But only about 10 to 15% of patients can ever have an operation because of all other mitigating circumstances. So therefore, the use of high-dose stereotactic body radiation therapy to approximate surgical benefits has more recently been talked about. But then what do you do when you have a treatment that is resistant cancer that cannot be removed surgically, right? So that's the answer that we're looking at. So a brief description of where we find ourselves anatomically. The local anatomy is typically where you see the tumor around this area near the pancreas. The surrounding normal structures are typically the duodenum, the liver, small bowel, and some of the vessels that go through in the vicinity of the tumor. The typical BED that is required to kill this tumor or to achieve control is essentially about 77 gray or higher. Now this is just a cross-sectional CT image with a typical pancreatic tumor, and the surrounding normal structures are illustrated here. You can see the small bowel. So this here is a tumor. So they do require high doses of radiation. But the one thing that does work for us a little bit here is that these does not work very well, is that these gastrointestinal critical structures are actually very radiosensitive. So one has to be very careful in coming up with dose regimens for stereotactic body radiotherapy. And we cannot be as fancy as we can be with, for example, say, lung tumors. So the typical dose fractionation that has more recently been seeing popularity is 8 gray times 5 fractions. And with the duodenal, the stomach, and small bowel structures receiving about 35 gray to less than 1 cc volumes. So again, these are just some examples of the various critical structures that are located right next to the tumor. As you can see, you have the stomach, the small bowel, and the duodenum that are right in the vicinity of the pancreas here. And so there's not really much room to play around with when you come up with margins and dose regimens. So very similar to what we have for a typical stereotactic radiation therapy process, we do have the three main steps, which is simulation. This is the step where we actually make the patient assume a pose that they are able to reproduce during the treatment as well. And then this essentially is used, this image set is used to draw the tumor and the critical normal structures around the tumor. Following this, we go to the treatment planning phase where we essentially design a dose distribution that provides adequate coverage to the tumor while sparing the normal critical structures. And then finally, once we have the treatment plan, we deliver the planned treatment using treatment machines that have onboard imaging, 3D imaging, such as CT on rail in this case. Now, the question can be asked as to why CT on rail is preferred, for example, say over cone beam CT, which is the more common image guidance option these days. The reason for this mainly is that the CT on rails essentially means that we have a diagnostic range scanner or diagnostic capability scanner at the treatment machine itself. And that can help reduce some of the crosstalk that you can see that results in poor soft tissue contrast from, say, a typical cone beam CT. But all that said, the newer cone beam CT machines that are coming out these days do have various features that can help improve, noise and soft tissue contrast. So the difference between the quality of images that you get, say, for example, on a CT on rail versus a cone beam CT might be getting smaller and smaller. But again, one can't cheat physics, right? So this is a true diagnostic scanner, so definitely you're going to get better image contrast or soft tissue contrast. Now, when we do this simulation, we do administer IV contrast for all our GI SBRT simulations. And in a lot of instances, these are actually done under breath hold. And this breath hold is typically voluntary. And we'll talk about that a little bit more. Are there any questions so far?
I think you're okay to move on.
All right, thank you. So the next step is the actual treatment. Let's talk about simulation a little bit more. So I did mention contrast. And the reason why we use contrast is to establish an artificial contrast boundary between the tumor and the surrounding normal structures. And as you can see from this graph here, so on the x-axis, you have the time in seconds, and then the contrast intensity as it goes through the bloodstream and other structures. And so different structures, so for example, the liver, the aorta, the liver met, the actual tumor itself, appear with a greater contrast at different stages of time during the actual contrast injection process. And so if we time our CT acquisition accordingly, we are then able to achieve a very good contrast between these various phases. And that's what we're doing here. So we are actually imaging both during the arterial phase, the and the venous phase, and even during the actual parenchymal phase. So these are some examples of images obtained with contrast and without contrast. And you can see here, how the administration of the actual contrast helps. So these images are actually of the no contrast situation, where you don't have the advantage of the enhanced visualization that is provided by using contrast, say, for example, here, where the tumor is clearly identified on the actual CT images itself. And so what this does is improve target delineation. And the various phases essentially means that when we acquire these repeat CT scans, now each CT scan is taken under breath hold condition and lasts about 10 to 15 seconds typically for an entire scan. So it's easy for us to acquire multiple scans over a period of, say, 1.5 minutes or even 2 minutes. And these are the various images that are then available to us to essentially do our treatment planning. And so this is an example of a pancreatic tumor. So if we just obtained a CT image with no contrast, then that's essentially what we would see. And as you can see, it's not exactly very clear. There's a lot of gray here. And even to a well-trained radiologist or a radiation oncologist, it can sometimes be very challenging to delineate the tumor on this CT image. And so when you look at these three different phases, so you have the arterial phase, the parenchymal phase, and the venous phase. So using these three different phases, the physician is then able to very accurately delineate the target volume. So this is just some more examples of a no contrast image versus the triphase contrast that I talked about. And this is the IGTV as shown here. What is also immediately recognizable is the presence of a clip or a BB inside the patient that's throwing off these artifacts here. And so if we looked at the actual patient setup that we use, we have the SBRT cradle with a wing board and a headrest. We provide the patient with some form of visual feedback. We are actually using the Varian RPM system along with a contrast injector. The RPM system does have its own interface for visual feedback. And so this is essentially like a blue bar. And this is the yellow bar that moves in and out as the patient breathes, moves up and down as the patient breathes in and out. And so what we ask them to do is after we set a particular level that is comfortable for the patient, we ask the patient to maintain this yellow bar within that blue background. And this is the screen that the patient is then able to see in the goggles. And so when the patient is actually moving this yellow and making sure that it stays in the blue, the respiratory trace essentially goes from a cyclical trace to essentially a flat line that fits within that breath hold level. And so we train the patient a couple of times initially to get familiar with the system, and then we acquire about 3 to 4. And so once these scans are acquired, they're all sent to the treatment planning system, where the main focus will be trying to get a dose distribution that delivers adequate dose to the tumor while sparing critical structures. There are different fractionation schemes for liver and pancreas that we've tried in the past. These range from 4.5 gray, as low as 4.5 gray per fraction, to about 10 gray per fraction. The number of fractions ranges from 5 to about 15, and the equivalent BEDs are shown here. And again, depending upon the dose per fraction, so starting with the standard fractionation through hypofractionation and SBRT, which is typically the highest dose per fraction, our normal tissue constraints get more stricter, right? Because as the dose increases, we want to make sure that we are actually hitting the right areas, and we also want to make sure that the surrounding critical normal structures are not getting any therapeutic dose, and they're spared as much as possible. And so this is how the target volume is volumes are contoured based on the number of fractions, or whether it is a standard dose per fraction or a hypofractionated treatment or an SBRT, which is typically about 5 fractions. So there is the actual gross tumor volume, and then there is the tumor vessel interface, which is also contoured, and there's a margin that's added around that. The surrounding normal structures, all like the duodenum, the small bowel, also have their contours drawn and a margin drawn around them as well. And then the actual tumor volumes are then subtracted from these to make sure that it is essentially this volume that's getting the high dose, right? So that's why you're subtracting the organ at risk volumes from the actual target volumes. And so this is a typical representation of a liver SBRT versus hypofractionation. So this is stereotactic at 5 fractions, 12.5 gray. And this is liver hypofractionation at 4.5 gray and 15 fractions. And as you can see, the dose fall off here is much tighter around the central volume. But it's also important to note that this particular liver segment that's being treated essentially is far away or far enough away from other critical structures that we are able to go to this high of a dose on this particular tumor. Whereas on the other hand, coming to this one, this is actually a lot more closer to other critical structures. And so we're not able to go to that high of a dose per fraction. So it's essentially being treated hypofractionation. And also the fall off that's around this is a little bit more shallower than compared to this one. Excuse me. A similar comparison for pancreas treatments is shown here. On the left, you have the SBRT, which is 8 gray times 5 fractions. Again, SBRT treatment. And then the hypofractionated version of the same thing, which is 4.5 gray times 15 fractions. And you can clearly see why we choose one of these two approaches based on where our target volumes are with respect to the surrounding anatomy.
Sastry?
Yes, sir.
I have a question for you. In terms of your SBRT for planning, how many arcs do you typically use?
Good question. So it's usually 2 arcs. We're able to get the dose. Sometimes we do have to use 3.
Typically coplanar?
Mostly coplanar, yeah.
Okay.
And actually, if I look at this more carefully, this seems like it's an IMRT plan, actually.
Most commonly.
Oh, sorry, never mind. I take that back. So these plans are all IMRT. They're not VMAT. And the reason is our CT on rail machine does not have a VMAT license. And so we have to treat these with IMRT. Sorry, I take that back.
Okay.
Yeah. But yeah, with VMAT, you do have the option of using multiple arcs. And for lung treatments, it's usually 2 arcs. Not 2 full arcs, but, like partial arcs. And so this is the setup we have at the actual treatment delivery room in the vault, where we have a standard linear accelerator and the CT on rail sort of facing each other. The couch is then able to swivel around for the imaging portion. The couch stays fixed. I mean, the couch top swivels, but the actual base stays fixed. Once the couch top goes to the imaging position, the scanner is able to slide in and out and acquire the images. And then once the images are acquired, we slide the patient back to face the machine and then verify that nothing has changed between the initial setup and the setup that we see after swiveling the patient back. Once we're confident that the patient hasn't moved, then we acquire another set of portal images to verify setup, MV portal images. And then once we are happy that that setup is good, then we are then able to go ahead and treat. And so this is the actual treatment delivery portion here. This is the 15 fraction treatment. See if I can play this. There you go. So this is the actual imaging that you're able to see. And what this is showing is the interfraction variation of GI anatomy as this thing is cycling through the different image sets that were acquired on different days. And shown here is another example. So these images were acquired on subsequent fractions, over 15 fractions, all acquired with breath hold, but you can still see that there are some residual, motion changes that happen even with breath hold imaging. And there are other concern sort of things that we have to take into account. because the patient sets up differently during every fraction, and breathing is also different on different days. So the GI anatomy does move and deform in unpredictable ways. So, for example, as you see here on day 1, this bowel is clearly invading the 36 gray line and possibly even the red a little bit here, which is a 50 gray line. But then after 5 hours, we sort of said, okay, well, let's hold off and get the patient back on the table after 5 hours and see where things are. So this was the reference, and this is where the patient is even after 5 hours. And there's no subsequent improvement here, as you can see. So there is some of this bowel that is actually entering the high dose volume. But then on day 2, with the same instructions and everything else being the same, you can clearly see that the bowel is no longer, in the actual high dose area, and then it's okay to treat. So these are some of the challenges that one will encounter when you're trying to do SBRT with breath hold. And so care has to be taken when we're doing the daily setup to make sure that our normal tissue structures are actually where we want them to be. And if not, we have to be sort of flexible enough to make sure to give the patient proper instructions, because some of this bowel position could in fact be because of changes in bowel gas or other things, local things that may be going on.
Sastry?
Yep.
I have another question.
Sure.
Do you all do any intrafraction imaging?
We don't have the capability to do intrafraction imaging on the CT on rail, but I can easily envision a situation where we have, say, for example, an exact track with a cone beam CT, or even just like a cone beam CT, like a 4D cone beam CT that can be acquired. One of the more recent developments is the MR, which I'm going to be mentioning a little bit more. Mm-hmm. In-room MR guidance is becoming, increasingly adopted with the MR Linac and its various incarnations. The MR Linac does offer the capability for real-time in-room imaging while the patient is happening. And we have actually run some test cases through that. We haven't actually treated anybody yet, but we hope to do so in the near future when we're able to do some breath hold based treatments on the MR Linac. And that, I think, will help us close the loop here, because there we can both look at intrafraction imaging in real time and also adapt treatment to account for daily changes in local anatomy and the tumor. Does that answer your question?
Yes, thank you very much.
Okay. And so, as you can see here, there are some, limitations and scope for a lot of improvements in this. So among the limitations are that the treatments are fairly long, and often the patients are on the couch for, close to an hour, maybe even later, and maybe even longer. That being said, the more newer machines have flattening filter-free beams and better tools such as fluoroscopy-based gating using fiducials, essentially not using soft tissue contrast. So the combination of all of these can potentially help, improve the fact that we need to deliver large MUs and with the patient on breath hold and be able to do this very quickly. So there is some potential for that. Now, with the CT on rail and the repeat breath hold, the assumptions are, of course, that the patient does not move during treatment. And as was mentioned earlier, that there is no intrafraction variation in the patient's anatomy. Another crucial assumption that we're making here is that the patient is able to consistently hold their breath in the same way. But as we all know, a lot of us, for many of us, we breathe with the chest, and many of us breathe more with the diaphragm. It just depends upon what we're more used to. And in some people that can change. So, sometimes they use the chest more, sometimes they use the diaphragm more, depending upon if they're breathing shallow or breathing deep. And depending upon what they do, that can change how the local anatomy, internal anatomy sets up, even though the external anatomy is actually setting up the same way. So that correlation between external and internal anatomy is a very crucial thing. And as I mentioned before, the MR-Linac, with its ability to do MRI-based gating, could potentially help improve patient setup. And also because of the better soft tissue contrast and the capability for real-time imaging, one can implement true real-time adaptive therapy for these types of tumors, and in addition be able to escalate the dose because we are able to see the target much better on a daily basis. And again, there's a whole different section that's dealing with ways to pharmacologically radioprotect the intestine. And so those techniques are also some potential improvements on that front. Another big thing, so these pharmacological techniques essentially involve, radiosensitizing the tumor to de-escalate the dose. So essentially what we're trying to do is not deliver too much dose to the tumor, but still be able to get the same response. And that's what we're going to be discussing in the next few slides here. So the hypothesis here is that selective radiosensitization of the tumor will improve the therapeutic ratio sufficiently to enable dose de-escalated therapy and therefore help minimize toxicity to the surrounding normal tissue. And then, so the central idea here is that since the effect of radiation is to essentially cause breaks in the DNA strands, if there was a way in which we can inhibit these repair mechanisms, then the damage that you inflict from the radiation dose can be greater, and we can actually achieve more radiation damage in the tumor with a lower dose. And then there are different sensitizers such as ATM, ATR, PARP1, DNA PKS, and RAD51 that are currently being looked at in different clinical trials. So as I mentioned before, the way radiation works in actually damaging tissue is both through a single strand break in the DNA and also a double strand break. Typically for low LET radiation such as photons, their main mechanism is base damage through a single strand break. But for high LET radiation, so the LET is for linear energy transfer, as we all know. For the high LET beams, it's usually through a double strand break, and so the damage is a little bit more harder to repair. Now, usually the repair happens through different mechanisms, either through a base excision repair. This is usually what happens in single strand breaks, or through non-homologous enjoining, which is a simple double strand break fix. For the more serious DNA strand breaks, the repair typically happens through homologous recombination. Again, I don't want to go too much deeper into all of these other than to just mention that these are the different repair mechanisms that happen, and one has to consider all of these into account when developing strategies to de-escalate the dose. So again, this is just another pictorial representation of what happens when we treat patients with high LET particles such as protons versus low LET particles such as photons. And so the idea essentially is to block the DNA repair mechanisms so that the cells are essentially radiosensitized. So these DNA repair inhibitors, so the radiosensitization can happen in different ways. So we can either limit the DNA repair using one of these mechanisms here, or you can take advantage of certain mutations in certain patients that already happen. So for example, in hereditary breast and ovarian cancer, the BRCA1 mutation essentially is defective, right? Leads to a defect in the DNA repair. So it's already present, and therefore in these patients, you typically don't need a high dose of radiation. And these are actually the patients that are more prone to acquiring breast and ovarian cancer, as we all know. So we could take advantage of either this mechanism here or use some additional DNA repair inhibitors in conjunction with the radiation. And then, of course, there is always this comparison between low LET radiation versus high LET radiation, such as protons, as shown here. So this is a typical photon dose distribution. As you can see, there is a lot of low dose spread around the high dose volume, which you can potentially limit by using protons simply because of the physics of dose distribution, using a proton beam, where we're actually taking advantage of the Bragg peak, which essentially delivers a good chunk of the dose at a particular depth and then essentially zero dose beyond that depth. And as you can see here, because of that, the dose on the distal side of this particular target is essentially zero as compared to a photon plan here. Again, this is an example of a proton beam treatment plan with a tumor. And so for the normal tissue, this is where we are, the normal clustered lesions. The idea is that we want to place the tumor essentially in that region where that damage is essentially going to be the maximal, right? And so we aim the Bragg peak to coincide with the area where the tumor is. So what you're essentially doing is the DNA damage that occurs here is essentially happening at a lower LET or a lower dose, because the dose here, the entrance dose, is essentially lower, whereas near the tumor, it's essentially higher LET or even a higher RBE, one could potentially argue, and therefore the damage is going to be more pronounced around the target. This sort of differential DNA damage is more possible with proton beams and, say, higher energy ions such as carbon ions, etc., particle therapy in general, but it's not nearly as pronounced with photon-based radiation therapy. So there is a lot of interest in these kinds of approaches as well. And so this is a simulation of how the BRCA1 deficiency makes the sense more sensitive to protons than photons. As you can see here, the survival fraction is much less for the patients who have the BRCA1 mutation and who are treated with protons. So there are some real benefits there and potential for dose de-escalation. And again, there are these various sensitizers, radiosensitizers, and how they act in conjunction to low LET radiation such as photons versus protons. And so if you actually look at the control group versus these other groups, you can easily see which of these ones is more useful for us in terms of de-escalating the dose. And so more recently, this approach has been used for the pancreas also, where they are interested in selective radioprotection of the GI tract using the Galera, which is GC4419, a superoxide dismutase mimetic, which selectively protects normal tissue. And the way this works is essentially the radiation induces a large burst of superoxide. And then the GC4419 is selective for this reaction, driving it towards hydrogen peroxide. Now, hydrogen peroxide is more toxic to cancer cells than the normal cells. And so if you're able to harness this difference, then we're able to protect the normal tissues more and then deliver a greater dose to the tumor. And so the mice studies that were done initially through Dr. Taniguchi's group here indicated that the survival actually was better with the SBRT when the GC4419 was administered to those mice as compared to the control where this was not. So there is some clear potential for using these radioprotective agents for normal tissues. Now there's also a phase two clinical trial underway. It's called the dose escalation trial of stereotactic body radiation therapy with the same radiomodulating agent in locally advanced pancreatic cancer. Dr. Taniguchi is the PI for this trial. And so these are the primary endpoints. Essentially, this is essentially a toxicity study, which is going to be essentially determining the maximum tolerated dose with and without GC4419. And then these are the various endpoints that are being tracked through the study. And these are the ways in which the different target volumes are contoured here and their doses, as you can see. So this is just a very typical representation of how the PTVs are essentially contoured and where the dose goes. So it's a very, very standard formulation of this trial here. And this is an actual representation of the same sort of targeting scheme on an actual patient CT scan. As you can see here, these are the three different dose levels, the PTV1, PTV2, and the PTV3, which includes some of the tumor vascular environment also along with the tumor here. This trial is expected to start national accrual very soon. Again, there may be a little bit of slowing down because of the whole COVID situation, but I think it'll start accruing very soon. And then finally, what we've seen here is that the radio protection in liver and pancreatic cancers can be achieved via margin reduction through accurate image guidance. It can also be achieved by selective radio sensitization of the tumor, thereby enabling de-escalation of the dose in normal tissue. And we can also achieve the same effect by radio protection of the normal tissue, thereby enabling escalation of the tumor doses. So all three of these approaches are of very great interest, and they've shown some promise. And then this is the group at MD Anderson that works with Dr. Sawaguchi, who have been instrumental in developing and maintaining this trial. That's all I have, and I'm happy to answer any questions at this point.
Awesome. Thank you very much, Sastry. I have a question. Are you guys actually doing SBRT with protons?
We are not doing SBRT with protons yet, but I think the slides that we showed were sort of comparative studies.
Okay.
And the reason is because image guidance at the Proton Therapy Center still hasn't reached a level of comfort where we would like it to be. And so for now, we're just doing these comparative studies. And then once we have the appropriate image guidance, we'll be able to start this at the Proton Center as well.
Okay.
But that being said, we also have the MR Linac now at MD Anderson. So that provides another benefit in the sense that you're able to achieve greater soft tissue contrast and real-time adaptive treatment. And so that's really opened up this trial to all these possibilities.
Right.
Sastry, thanks so much for sharing this presentation. So it looks like two of the centers who are on the call today, so we have 6 centers from Peru and Colombia,
okay,
have already started doing some liver SBRT for the first time. I think Clínica Auna has done about 15 cases, and then Peru's National Cancer Center has also done a number of cases. But for a lot of people in the audience, they haven't done liver SBRT or pancreas SBRT. I thought it might be helpful. What do the different toxicities look like for abdominal toxicity comparing SBRT versus conventional fractionation?
I hope I could, I wish I could give you a good answer for that. It's more of a clinical question than a physics question, I would say at this point. But as with SBRT treatment, the main worry that you have here is the bowel and the duodenal toxicity because they're like so close. And with liver, again, depending upon where it is, one has to be sort of cognizant of which area or which segment of the liver we are treating. As I showed here, for example. Like, yeah. So for example, here we were able to go to like 12.5 gray times 5 without too much of a problem, but we couldn't use the same regimen for, say, this volume here. So we really have to have this sort of like a graded approach towards hypofractionation, and there's not like a one size fits all.
Thank you.
I hope I answered the question, but if there's more information, I can always get it from the appropriate clinicians.
I believe David Martinez had a question about fiducial markers. Is that correct, David?
Yes, thank you very much for your wonderful lecture. I would like to know if you use fiducial markers when you are about to treat pancreatic cancer.
Very good question. Thank you. Yes, we do use fiducial markers. However, the implementation of that has been very spotty because we have our own bureaucracy, essentially, for lack of a better word. We're not able to implant the fiducials in the radiation oncology department. It has to be done outside. And so there's always this back and forth going on. But every chance we get, we do try and get some fiducials in there.
So when you have the fiducials implanted, when you do your imaging, you base your alignment mostly on the fiducials, I assume?
Yes. We use that as a guide and then make like a best guess estimate of where the target is in relation to the fiducial, because one has to also, be aware that the fiducials can shift during a treatment course.
Yeah. Another question, for each of your SBRT treatments, is it your protocol that there is a physicist present for the entire treatment?
It's a very good question. So since we have this graded approach for the SBRT fractions that are like 12.5 gray times 5, we have to have both the physicist and the physician present for every fraction. For the other ones where it's like 10 fractions or 15 fractions, we have the physician present for the first fraction along with the physicist. And then for the other fractions, it's usually just the physicist doing the alignment with the therapist. And then the physician sort of checks in once a week to make sure that things are still okay.
Are you also present for simulation?
Yes, we are. Okay. Because we have to make sure that the contrast is, handled appropriately. And the therapists have been trained to do this very well, but just to ensure consistency, because the therapists kind of rotate in and out, to make sure that everybody's on the same page.
And Sastry, do you remember what it was like the first time that your center was transitioning to do pancreas SBRT and liver SBRT for the first time?
I'm sure it was very exciting and scary. I will confess I was not involved for that first treatment. It was probably Dr. Sawakuchi, and he would express a very similar sentiment. But that said, we've had like prior experience with a very strong lung SBRT program. So it's not like we straight away went into liver SBRT and pancreas SBRT. We have a lot of experience with lung.
And from a physics perspective, do you have a recommendation one way or another for if a center obtains new equipment and wants to start doing SBRT? Should they try to get used to lung SBRT first before moving to abdominal SBRT?
I would think so, simply because with like these smaller lung tumors, you're able to delineate them better, and you don't always need breath hold. You can easily do a 4D CT to determine which ones move and which ones don't, and start off by treating those that don't move that much because you don't need breath hold in those instances. To a certain comfort level with that, and then start addressing these tumors that actually move. And then once you gain some comfort level with that, you can then move towards, the abdomen.
I would like, sorry, I would like to ask you about the transition that your center have to do when you started the treatment for liver SBRT to give higher doses as we are doing now, because I see you are doing 12.5 for 5 fractions.
Right.
And we started at 40 gray in 5 fractions. So we would like to increase maybe the dose, but how are you feeling now with these treatments and the toxicity that you are seeing in your face?
I think people are very comfortable right now with this. So for a long time, we were also actually doing 8 gray times 5 for most of these cases. And this 12.5 gray times 5 is a more recent development based on all the results that we were seeing from our initial experience. So it's not like we just straight away went to 12.5 times 5. And right now we're, very comfortable where we are. The one thing that I would like to sort of mention here is that with the breath hold imaging, sometimes people think that it's enough to just do like 3 breath hold scans. But what we have found in some instances is that that may not be enough, and we probably need a bigger sample size. And there's also some systematic difference between how patients hold their breath at simulation and then what happens at the time of treatment. So there is some potential there for mistreatments or like a geographical miss. And it has happened in some instances. So just to be careful about, not limiting the number of breath hold scans. Now you can actually decrease the number of MAs per scan that you take for the breath hold, but the more number of samples that you have, the better.
That has to do a little bit with a question that I was going to ask, but I actually didn't. When you are coaching your patients in a breath hold, do you prefer that they, like in terms of breathing, chest breathing and belly breathing, do you help coach them to do one versus the other?
So when they're actually set up and ready to do this, we essentially ask them to close their eyes and hold their breath at a comfortable level. We don't instruct them to do one versus the other, because at the end of the day, we want them to do what is most comfortable for them. And then we don't ask them to take in a deep breath and hold. It's just like, tidal inspiration and then hold the breath there. Once they've done this with their eyes closed, then we actually give them the goggles and ask them to use the goggles and see where they are. And that way, we're just keeping them at their most comfortable level on a day-to-day basis.
Okay. Okay. Let's see. Are there any more questions from the audience? You can either turn your mic on and ask a question, or if you want to enter a question into the chat, we'll give you another minute or so to do that. Si alguien tiene una pregunta, puede prender su micrófono a Dr. Vedam, o pueden ponerlo en el chat. Okay. Just wait a minute or so more. Seconds.
Mike.
Yes.
Sorry, I would like to ask also about those that you are using in pancreatic SBRT.
Yes.
Which dose are you using now?
Let me go back to that slide. So these are the different doses that we've tried so far. So it can be 5 times 10 or 6 times 10. I think we did start with like 4.5 times 15, and then it gradually went down to 6, 7.5, 7.2, and then 10.
Okay. Thank you.
You're welcome.
Okay. I believe with that, we can conclude this session. We're very grateful, Sastry, for the time that you've given to us to present this information. It's very interesting, very informative. It was very cool to see how MD Anderson in Houston really is doing these things, since they are, the leader in just about every aspect of radiation therapy. It was a very interesting dive into your guys' realm.
Yeah, no. Well, I do thank you for the opportunity, and I appreciate all the discussions.
Estamos también muy agradecidos a todos que han atendido esta sesión, que la próxima sesión será este jueves y será dado por Dr. Hiram Gay de Washington University, y él va a hablar en cuanto a SBRT del Prostatat. Okay, and with that, we can conclude this session. Thank you very much again, Dr. Vedam.
All right, thank you all. Appreciate it.
Thank you.
Bye.
Take care, everyone.